Okay, once again, good evening to all of you, and this is again another session of ICU Room Uncut Academic Discussions. So, today with me is Dr. Kishore, you have seen in the previous video, Dr. Garima with us, and we have Dr. Radhika. Hers is first day in our ICU, she has joined today itself, and unfortunately, she is sitting in the discussion panel. So, Dr. Kishore has seen a case in the ER yesterday, and we'll be discussing that case, and we are not disclosing what is the case right now. Let's see how the case evolves. So, okay, Dr. Kishore, tell me about the case.
Yes, sir. One patient came to tomorrow in yesterday.
Before starting, again I am reminding you, this is the uncut version. That means all these people who are sitting here, they are also learning intensive care. They are freshers in ICU, and what we want to show with this uncut version is that the learning process is same everywhere. You just need to develop the approach in treating patients. It's not about knowing something or not knowing something. It's how you approach certain conditions, the way you evolve. So many things I may not be knowing, many things Dr. Kishore or anybody may not be knowing, but where we stuck up, we go and read, and then we'll come back. We'll have a detailed discussion in our lecture series, but this is uncut version where we discuss as a raw the routine cases. Okay, Dr. Kishore, with that start.
Okay, sir. Thank you, sir. A patient came in ER with a major complaint, dull, drowsy, with altered sensorium, and so first of all, we say an hiccup. Since last 15 days, he is suffering from fever and treated under local physicians for the pneumonia. When he came in our ER. We saw the patient, and the patient was suddenly got one episode of GTCS, and then he got brady arrest. Okay. So we are, according to the SLS protocol, we immediately start the CPR and airway protection, ADR, and then shifted to MICU, sir.
Okay, so now I don't know the case. I know obviously, but suppose I am a consultant who is not knowing the case. I am just listening to the words Dr. Kishore is or XYZ any resident is telling me on the phone or narrating me. So there are some things lacking. Means when I am hearing some student or when I am hearing some student from ICU, emergency, doctor or any resident, I should get a picture that what is the patient. I should be able to picturize the patient, and I should know what is going on with the patient. Now the first thing in this category is identification of the patient. Identification means patient's age,
yes,
patient sex, yes, patient's previous conditions, now the presenting complaint, that should be known.
Yes.
No, so Dr. Kishore has narrated, but I am not able to figure out whether it was a kid, whether it was a middle-aged man, whether it's a young fellow, yes, or whether it was a senior fellow. So first thing, XYZ means, yes, so and so age, year old, male or female. Yes. So yes, what?
Sir, 59-year-old male.
Okay, so I got a picture that it is a 59-year-old male with previous comorbidities or previous complaints. So it will help me to narrow down the differentials.
Okay.
So 59-year-old male with previous comorbid history of
pneumonia. And
pneumonia is a recent one.
Recent.
Medical history. Does the patient has any diabetes?
No, sir. No comorbidity with HTM and diabetes.
So 59-year-old male with no previous comorbidities presented with 15 days back history of fever on and off.
Yes.
Then he was diagnosed somewhere else outside as a case of right-sided pneumonia, and then he was not improving, and for the last 3-4 days he was becoming dull and drowsy, and then he got transferred or shifted to our hospital. So I get an idea what is the patient, what is happening with the patient's comorbid conditions, helps to narrow down the differentials. But now I have an idea that what we are dealing. Okay, so he had a GTCS episodes in the ER, and then revived, and we shifted to MICU. So first we'll discuss what are the causes of dullness and drowsiness. So how will you approach a patient who presented with altered behavior? Yes. Means altered behaviors, or neurologically he's showing some fluctuations. So how will you approach that?
Sir, we find some investigations.
Investigation. What are the differentials you will make?
Hepatic, so encephalopathy, metabolic encephalopathy, and we'll took ABG, arterial blood gas
We'll do
analysis.
investigation only once we need to narrow down or choose what is the diagnosis. We need to confirm a diagnosis.
Yes,
First, we need to rule out the causes.
So hypoglycemia.
Hypoglycemia, sir. Hypoglycemia.
Okay, so the best thing to approach is, because of the time constraint, because I'm telling you the concept, whenever some neurological condition happens to a patient, you need to broadly classify into three things. One is ornic cause, means something is there in the brain, whether it's a bleed, whether it's a stroke, or whether some solitary mass, or whether there is could be a tumor, or whether it's a venous sinus thrombosis. Something ornic is happening in the brain. Secondly, you have some infective cause. This patient was having pneumonia, so whether it is septic encephalopathy or whether it's a meningitis, encephalitis sort of things. In the third category, we'll put the non-infective ones, metabolic ones: hypoglycemia, hyponatremia, ammonia, hepatic encaph, and hyperuremia. So this way you divide. So did you find any localizing? So first we rule out whether there was a ornic cause. Did you find any localizing signs when the patient came?
No, sir, I didn't found.
So there was no localizing signs. Patient was moving all four limbs. There was no deficit, but patient was dull. So we shifted our diagnosis to second category and third category. Second category means the patient could be having septic encaph or could be having primarily meningoencephalitis. Patient was having history of fever also, though it was labeled for pneumonia, but there are chances that altered behavior with fever, there is always a possibility. So this is one thing we will keep in differential. Still we have kept this thing in the differentials. And this third, metabolic, any metabolic thing you could find out? Any metabolic parameter we could find out?
Yes, sir.
What?
When bilirubin will be rise 1.2.
Any metabolic factor which can lead to this seizure and this presentation, did you find in this patient?
Yes, sir. Hyponatremia.
Okay, so hyponatremia was how much was the hyponatremia?
95 will be sodium level.
So hyponatremia is very strong evidence which we got in this patient. So this case, now we give preference. Now in differentials, the infective one came down and the metabolic part has jumped up in the differential. Earlier we was thinking that is due to some pneumonia or encephalopathy or fever or meningoencephalitis. Now because the metabolic panel is so strong, you got hyponatremia that is so severe. The normal range is 135 to 145.
Yes.
Then patient usually have symptoms somewhere around, if up to 120 they have certain symptoms, below 120 usually have different symptoms. So the important thing in whenever you see a patient of hyponatremia, always inquire for with how much pace this has developed, whether this is an acute event which has developed in the last 3-4 days, or this is a chronic one over a period of months, or chronically the patient is there. Then just labeling hyponatremia, that this incidental finding that this patient comes to your emergency and sodium comes out to you 125, that doesn't mean that patient is having symptomatic hyponatremia. It could be chronic one and patient is not showing any symptom. So now this patient is having severe hyponatremia, less than 100, 95. Obviously this can be cause of GTCS. Yes, sure. So now how will you approach this hyponatremia?
Sir, our first target is the correction of the hyponatremia.
ABC you have already managed, that you have done the CPR and you have stabilized the airway breathing circulation. So now after doing this stabilizing the patient, how will you approach?
Sir, we approach first of all, sir, our main approach target is correct the sodium level in body. So sir, in first hour we want to correct at least 5 milli equivalent sodium.
Okay.
Either by hypertonic solution, 3% hypertonic solution, or a normal bolus solution.
Okay.
Then our target will be next for 24 hours. We want to correct at least maximum up to 10 milli equivalent.
Okay.
And after that, sir, another day maximum 8 milli equivalent, sir.
Okay, so what we are discussing is whenever you see a severe hyponatremia, the patient has GTCS and coma sort of condition. Now with how much pace you need to correct.
Yes.
So in hyponatremia, it is very important that the pace or rate of correction you need to define, because if you do too much, what complication the patient can have?
ODS.
Osmotic demyelination. So whenever there is a shift in the osmolarity of the blood, it hampers the brain, and it causes demyelination, which sort of, it is usually permanent, and it, or if not permanent, can damage to the brain. So how much hyponatremia you need to correct, we need to figure out. Before now in emergency in ICU ward, two things goes hand in hand. One is the correction of the disease which you are saying, second to find out the cause of disease. So first we'll complete the rate of correction. The rate of correction for any hyponatremia means whatever hyponatremia you have seen, the rate of correction in the first 24 hours should not be more than 12. As a safer side, we keep it 10.
Yes.
And after 24 hours, the rate of correction should be maximum 6 per day, 6 per 24 hours. So it's a gradual correction.
Yes.
Now suppose there are many formulas which we will take in the detailed sections on hyponatremia, how to approach hyponatremia, but this is an uncut version, so we will discuss only the practical aspects. So there are many calculations, how much fluid you should give, how you correct, but because this is a GTCS case, you need to correct with 3% saline or hypertonic salines. In some countries 21% is also available, but they use it for brain edema.
Yes.
So what hyponatremia does is, because it is a major solute in the intravascular compartment, because sodium is less, so free fluid gets shifted into interstitium and then into the intracellular compartment, it causes brain edema.
Yes.
That is the cause of all these symptoms. So in first 24 hours you need to correct with 3% saline and hypertonic saline, and the rate of correction not more than 12. Now we are correcting it, but suppose it gets more corrected. You are monitoring every 6 hourly or at least every 12 hourly, you are monitoring the sodium. Suppose it gets corrected too much. Suppose in this patient there is 95 is the sodium, and you get corrected, it shoots to 115. So more correction is more than 120. So how will you do that? How will you manage?
In case of hypernatremia.
When over correction of hyponatremia in 24 hours, because we are monitoring every 12 hours or 6 hours. Suppose you have started and now the rate of correction is shooted up.
Yes, sir.
Nobody in the world can predict how much the patient will respond to that thing.
Give NS normal. So we can give NS.
Means you want to
Correct the volume.
So you need to, you are saying that you will correct, you will stop the 3% and give the
Yes, sir. Fluid.
But 3% also contains sodium.
Yes.
Normal saline also contains sodium. Some sodium is there.
Yes, sir.
So the what I want to tell you, that in books it is written, if it is getting over corrected,
Yes, sir.
you need to bring back to that sodium within that 12 range.
Yes, sir.
Suppose on 8 am you started with 3% or something, and your target shoot to more than 12 or 14 or 16 in next 12 hours. You start free water through rice tube.
Yes, sir.
You can supplement dextrose containing some solution, so that your in 24 hours your sodium comes within that 10 to 12 range.
Okay, sir.
Okay. So this is for tiding over the emergency. That we have to give hypertonic saline because this was GTCS and sort of coma condition. Now comes the second part, that you need to correct hyponatremia. So basically hyponatremia means there is a balance, means disturbance in the balance of water handling of the body. It's not the solute, it's not the swelling. So hyponatremia can be in 3 stages.
Yes, sir.
You have an intravascular volume.
Yes, sir.
Either it can happen that sodium is normal but you accumulated more fluid, like CCF, renal failure,
Yes,
or any other condition, so it gets diluted. So it is hypervolemic hyponatremia. There is a condition in which sodium and volume status remains same, but there is a hyponatremia. So it is euvolemic hyponatremia. And there is a condition in which actually there is a loss of sodium and the patient is hypovolemic.
Yes, sir.
So that is hypovolemic hyponatremia.
Yes, sir.
So these 3 conditions. So first thing you need to understand is, we need to first check whether this hyponatremia is true or not.
Yes, sir.
So for true or not, you need to calculate the osmolality of the blood.
Yes, sir.
Calculating the osmolarity, there is a formula.
Yes,
With
sir.
sodium, glucose and urea, you can calculate how much is the osmolarity. If osmolarity comes less, that means it's a true hyponatremia.
Yes, sir.
Once you have established that it's a true hyponatremia, if the osmolarity is less than 284 or something, then you need to see the volume status.
Yes, sir.
So there are many things written in the books that you can calculate the volume status by clinical examination, doing your urine osmolarity or doing the blood gases, but it's not so easy. But mostly when you clinically examine the patient, mostly you get an idea that we are dealing with a dehydrated patient, we are getting a euvolemic patient or the CCF or renal failure. So volume status is very, very important. We also advise that whenever do a serum osmolarity, send serum osmolarity plus urine osmolarity also.
Yes, sir.
Kidneys are very wonderful in managing the balance. So suppose you have a means you have differentiated into hypervolemic, euvolemic or hypovolemic.
Yes, sir.
So for hypovolemic you need to give by fluid challenge.
Okay.
Don't, if in a dehydrated patient, or usually we see hypernatremia, but if it is a hypovolemic patient, maybe because of diuretics or something, if you start correcting by 3% saline, they get corrected very fast. So we say if you want to correct hyponatremia in a hypovolemic patient, start with fluids because it gets very rapidly corrected. In euvolemic and hypervolemic, in hypervolemic CCF and renal failure is usually due to fluid, so getting rid of the fluid is more important rather than supplementing sodium. So it's also a marker how much disease is severe. In CCF, if there is a low sodium, in renal failure it's a fluid overload. So if we need to dialyze the patient or we need to give diuretics to the patient, that's a different approach. Now the questions comes when both are not, we are in doubt whether it is not euvolemic, it is not hypovolemic, it is not hypervolemic. It is a euvolemic sort of patient which is having hyponatremia. Then your search should start to find the cause. One of the most common causes is diuretics, thiazide diuretics. One of the most common causes is thiazide diuretics which cause hyponatremia. So you should always inquire whether they are taking some medicine which has H in it. Then you have in ICU you have neuro patients also. In neuro patients there is a condition called cerebral salt wasting also. So you need to compare your serum osmolarity with urine osmolarity. Suppose you have serum osmolarity is less than 100 and urine sodium is also less than 30, means kidney is pouring less. We are talking about urine osmolarity and urine spot sodium. We need to see. So urine osmolarity is less than 100 and serum sodium is also less than 100, means kidney is pouring dilute urine and kidney is also sodium content is less. So what could be the cause?
SIADH?
SIADH में different. In this means this is excessive water patient is taking.
Okay, polydipsia.
For a patient is taking excessive water, dilute urine, dilute sodium, it's urine. Now, but suppose the kidney is pouring concentrated urine in which sodium is urine osmolarity is more than 100. Concentrated urine, but your sodium is low. Patient is pouring urine which is a concentrated but preserving sodium.
Hyperosmolarity. So sir, that could be
SIADH. No. That could be patient is passing concentrated urine but sodium is preserving. Patient is hypovolemic.
Okay, sir.
Effective circulating volume is less.
Yes, sir.
It can be due to hypovolemia or it can be due to your third space loss. Means body is trying to preserve sodium, body is trying to conserve the water, but it is not able to do that. So intravascularly patient is depleted.
So
But if your urine is concentrated, but kidney is pouring sodium in that, sodium is more than 20s or 30s in the urine, means patient kidney is preserving free water but is releasing sodium. Then here comes with SIADH. Then you can have adrenal insufficiency, then you can have cerebral salt wasting. In cerebral salt wasting, I think they pass sodium also in that. So, and there is no concentrated urine also, but concentrated urine but high sodium in urine. So it can be SIADH, adrenal insufficiency, hypothyroid, and one more thing which I am missing is SIADH. Okay, so salt oozing nephritis. These are the conditions. So this was not a okay. So this is not a lecture about detail about approach to hyponatremia. We are just discussing the case as it evolves. So now 24 hours have been passed out. Kishore,
Yes, sir.
people were asking, we wanted to listen you yesterday. So 24 hours has passed. We have sodium now 105
Yes,
in this particular patient. Now patient is on ventilator. Now how we will move out from there? Are you still looking for any other cause other than hyponatremia?
Yes, sir. We are searching for the cause of hyponatremia. कि why suddenly hyponatremia cause? And we taken the history from his family member. कि what the treatment previously he is taken.
Okay.
Okay, but they are not able to give the prescription of these doctors.
Okay.
So we approached to कि maybe it might be possible कि he taken the thiazide derivatives.
There could be one possibility.
Yes, sir.
Another thing, there is one. This patient also had history of pneumonia.
Yes, sir.
So there are some. There is one pneumonia which causes pneumonia with hyponatremia.
Yes.
There is one. I think Legionella is something which causes this sort of pneumonia. If I'm not remembering right.
Yes, sir.
So till we don't find an evidence that this patient has taken thiazide, will not label as thiazide diuretics. That could be pneumonia which is cause hyponatremia. I think Legionella is there, so we need to cover. Secondly, if the patient doesn't improves in next 24 to 48 hours, the sensorium doesn't improve, then we need to look for other causes, whether there is infective cause also. We need to do brain imaging, we need to do what was the cause of GTCS, or we need to do for CSF, and also we'll see the adrenal insufficiency and other causes which has led to this hyponatremia. So all these discussions are not to train you fully about the topics. For that, the separate lectures are there in which we approach a particular case. Means like hyponatremia, I'll make one topic on hyponatremia. The purpose of these uncut discussions is that how you should approach the cases, how you should communicate, how you should, your thought process should be there. So I thank Dr. Kishore for reading and coming today.
Yes.
Dr. Garima has already you have seen previous, and welcome Dr. Radhika. She will be also on this seat sooner. So thank you for today, and do tell us in the comments whether you people are liking these uncut versions or not. Should we continue these or not, or you are getting now some odd bore for next some 20 minutes. Thank you.
Thank you, sir.